Great. Welcome everyone to the webinar on cross-agency approaches to preventing and treating substance use disorder. I'm Deborah Fournier. I am a Senior Director with ASTO, and my co-moderator today is Kitty Purrington, who is a Senior Program Director for the National Academy for State Health Policy, otherwise known as NASHP. ASTO and NASHP are so pleased to share a set of national recommendations that have been developed based on the insight of the members of the Cross-Agency Leaders Roundtable. They focused on concrete strategies to work across Medicaid, public health agencies, and sister agencies to stem the tide of substance use disorder and effectively use state resources.
Great, thanks, Deb, for getting us started. Can everyone hear me?
Yep.
Hi, it's Kitty. Can everyone hear me?
Yes, we can.
Yep. Great, thank you. So ASTO and NASHP are very pleased to be joined by Dr. Rachel Levine, Pennsylvania's Secretary of Health, and we will also be joined by Michael Freeman with the California Department of Healthcare Services. And we are going to begin by sharing a brief overview of our work over the past year. Following that, we're going to dive into more detail on some of the great work that's been spearheaded by Pennsylvania and California. And we will also have some time at the end of the webinar for some discussion with our participants. So I'm just going to speak very briefly to the scope of the issue. And as we all understand, the opioid epidemic, as well as other substance use disorders, are critical issues for state leaders, really across every state in the country. And I'm sure everyone on the call is very familiar with the grim statistics on this slide. For instance, that over 130 people are dying every day from opioid-related drug overdoses, which is enough to be a drop in the overall life expectancy in the U.S. In response, we've seen a great deal of activity at the federal, state, and local levels using a host of different strategies and approaches, and we're going to hear about a few of these today. States are very much on the front lines on this issue, with concerted efforts across legislative, executive, and judicial branches. Governor's offices are making this a very high priority issue. There's, I think a growing recognition just across our culture that addiction is a disorder that requires both treatment and recovery services, but also upstream prevention strategies. In our work with states at NASHP, we see that no one sector of the state healthcare system can really tackle this issue in isolation, and that there are some especially fruitful work that can happen at the intersection of public health and Medicaid. And this slide shows that some of those things that state agencies can do together are things like share data, align priorities, and stand up cross-sector collaborations are the kinds of things that can help amplify the impact of both state agencies and state work across the spectrum.
So understanding both the scope of this epidemic and the benefits of partnership, ASTO and NASHP put our heads together and launched a roundtable of Medicaid leadership and public health leadership across a variety of different states. They're shown here, that have taken concerted efforts to work across agencies and within an administration to address substance use disorder, to curate promising strategies and practices for other states, and hopefully to be able to begin to prevent substance use disorder writ large. We invited those state leaders to join the group in early 2018, based on a scan of multi-sector activity that was undertaken by both NASHP and ASTO. And then we conducted 4 virtual convenings with our members throughout the year, in which the states were each asked to highlight the work that they were doing in a particular facet of their multi-sector SUD work. And then all of that culminated with an in-person meeting this past December, where we had curated the work that had been presented throughout the year and tried to distill it into some draft recommendations. And then the group together in person worked through those recommendations to finalize them. And those are the ones that we'll be presenting today. We are so proud to have been able to conduct this project in support, with support from HRSA and in partnership with NASHP. And we should, of course, point out, however, that the findings or conclusions that presented today are not necessarily those of our federal partners. So we're going to go over briefly our recommendations, and then our speakers are going to highlight them, I think, in more productive ways, perhaps. So the first recommendation is to determine an appropriate mechanism to catalyze cross-agency collaboration and create a unified administrative structure. So we've seen states pursue public health or emergency declarations to bring together new partners, and even in some instances form a central command structure. And in other states, we saw that partners came together voluntarily through goodwill or external foundation philanthropic support. But regardless of the impetus, whether it's legislative activity or executive authority, what we learned in this initial recommendation is that it's important to have deliberate, regular meeting structure so that partners, one, are accountable for follow through, and two, share a set of common goals that they are striving to reach together. We also learned, as Kitty mentioned earlier, in terms of multi-sector collaboration, that wide representation is critical, and that it should go beyond the traditional health actors. That bringing together public health and Medicaid within an administration is critical, but that also bringing criminal justice, law enforcement, education, labor and industry, pharmacy boards, and other licensing boards or regulators into the stakeholder fold is absolutely essential.
Great, thank you. And we also, in our conversations with states, ASTO and NASHP, also heard that once states have this central administrative structure in place with a wide variety of stakeholders at the table, state agencies can then begin to use that structure to explore policies that can allow for a nimbler response to the evolving SUD trends that they're seeing in their states, and to effectively distribute finite resources and leverage what they have. And some examples that we have seen include aligning and amending contracting requirements to ensure efficient distribution of state funds, building off existing programs and structures, and also blending and braiding funding between state agencies. So having that mechanism to sit around the table and identify who has what available resources can be really fruitful.
Thanks, Kitty. So we also learned that although both public health and Medicaid work directly with providers, and they both therefore have can work to improve uptake of evidence-based practices for screening for SUD, for treating SUD, and hopefully for preventing SUD. And public health and Medicaid agencies are focused on trying to bridge the gap between prevention and treatment by expanding access to naloxone, setting prescribing guidelines, sometimes which are prescribing guidelines for all providers, not just those involved in Medicaid networks, and offering training for providers about appropriate prescribing behavior, as well as taking steps within a Medicaid program, for example, to eliminate prior authorization requirements for medication-assisted treatment. Specific mechanisms that incentivize uptake of best practices and ongoing recovery were also highlighted. And those included adoption of value-based payment models or contracting requirements within the Medicaid managed care system, and between the state and the managed care organizations, as well as between the managed care organizations and their providers, and including quality improvement incentives or requirements in those contracts were essential.
Great, thanks. And our final recommendation reflects the work that we've heard, a lot of innovative activity regarding the use of data. State leaders have been casting a wide net, understanding available data resources, and then merging these data resources to use in a number of important ways. Often states are using this merged data or broader data picture to identify trends within their population at risk of SUD, hotspotting and things like that. Also using it to communicate information with the public and prescribers through publicly posted dashboards and things like that, and also to measure progress on their initiatives. And new data sharing authority can be facilitated by state legislation, by executive order, or through disaster declaration that can kind of facilitate in sharing data that is not otherwise shareable across state agencies.
And then finally, everyone in the group recognized that they all wanted to go upstream, and they all wanted to incorporate upstream prevention into existing SUD program and policies. There is certainly, as I said, an overwhelming recognition about the importance of this. But the leaders, when they worked together, actually articulated that the importance is also in building resilience at a community level in order to really move far upstream around prevention of substance use disorder issues. And while there is certainly recognition that this need is there and that it's a priority for everyone, the mechanisms and strategies to accomplish this turn from individual treatment towards community-wide prevention is still in a more developmental state. Some, however, of the specific strategies that states can consider are those such as emphasizing uptake of ASAM level 0.5 everywhere in the state, supporting non-clinical workforces and place-based initiatives that build on those links between clinical care and community care and that improve health-related social needs. Beginning to screen for and collect data on ACEs, adverse childhood experiences, and then using that data to target mitigation or prevention efforts. And of course, addressing stigma around SUD, which can also include addressing things like problematic language that exist in regulation or statute. And we have here, so that it's more people-centered and not disease state-centered. And then probably the most dominant determinant of health that the group could identify was the need for recovery housing and how to explore access for that. So this is the very brief version of these recommendations. I'm now so happy and proud to turn over to one of our state health officials, Dr. Rachel Levine, who is from the Secretary of the Pennsylvania Department of Health, and she is going to help illustrate what these strategies look like in action. Dr. Levine, I turn it over to you.
Thank you so much. Good afternoon. And I have been so pleased to participate in this collaborative effort between ASTO and NASHP. I certainly found the phone calls and the meeting in California to be very valuable. And I'm very pleased to participate in this webinar. Next slide, please. So, of course, the opioid crisis is the biggest public health crisis that we are facing in Pennsylvania. Pennsylvania has been unfortunately, one of the epicenters of the crisis. And we have been working on that all through Governor Wolf's first term. In January of 2018, the decision was made to issue a disaster declaration in response to the opioid crisis. These are 90 days in length, and actually today we issued the 6th iteration of the disaster declaration. This allowed us to create the Opioid Command Center and Unified Coordination Group. And so this involves actually 16, now 17 state agencies that all come together at the Pennsylvania Emergency Management Association on Monday morning at 9:30, and we work on collaborating to address the opioid crisis in Pennsylvania, each from our own perspective. So this includes, of course, our department, the Department of Health. We work very closely with our sister agency, the Department of Human Services, and that's where Medicaid resides. And then there's a Department of Drug and Alcohol Programs, Department of Aging, PEMA, as I mentioned, and then public safety, including law enforcement. So the Pennsylvania State Police are at the table, the Department of Corrections is at the table, as well as the Pennsylvania Commission for Crime and Delinquency. And then you add lots of other agencies, Labor and Industry, Department of Education, Military Veterans Affairs, etc. We have 3 pillars to our response, 3 categories to our response. The first is prevention. The second is rescue with the medication naloxone. And the third is expanding treatment. I will be particularly highlighting our prevention efforts, but we can talk about some of the others as well. Next slide, please. The term that I like to use for some of our prevention efforts is opioid stewardship, and that has where I have focused my efforts. Of course, there have been prevention efforts in the schools, which involves a collaboration of the Department of Drug and Alcohol Programs and the Department of Education. There also have been community prevention efforts through the Department of Drug and Alcohol Programs, but where I have been spending most of my efforts and really in the wheelhouse of the Department of Health is in working with the medical community to learn to prescribe opioid pain medications more carefully and judiciously, thus the term opioid stewardship. Opioids actually are essential medicines in medical practice, and if you're at the hospital down the street and you had a major car accident today and you have a fractured leg, you need an opioid because you're in severe acute pain. If you had a major operation this morning, then you would need an opioid for that type of acute pain. For patients with certain types of chronic pain, such as cancer pain, end-of-life pain, palliative care, we need to prescribe opioids. We do not want patients to suffer from acute or chronic pain. But clearly, one of the main contributing factors to the opioid crisis has been the overprescription of opioid pain medications for mild to moderate acute and chronic pain over the last 20 years. And so we are working very closely with our medical colleagues in all fields on this concept of opioid stewardship. I'd like to highlight some of those efforts. One is that we have well, let's outline what they are altogether. So we have prescribing guidelines, we have done medical school education, we have done continuing education for providers, prescribers and dispensers, and our prescription drug monitoring program. So we're going to go over these in more detail. Next slide, please. So we have written a number of opioid prescribing guidelines in Pennsylvania. And these are all synergistic with the 2016 Center for Disease Control, CDC, prescribing guidelines. But they were specifically for primary care providers and patients with chronic pain. So ours are a little bit broader, but they are synergistic with those guidelines. So you can see a number of them listed here. So we have pediatric and adolescent guidelines. We have geriatric guidelines. We have emergency department guidelines for acute pain. We have chronic non-cancer pain guidelines. This includes OBGYN, orthopedics and sports medicine. We have workers' compensation guidelines, dental guidelines, pharmacist guidelines, etc. And so these have all been written by a task force, a prescribing guideline task force. A committee is developed of content experts, say in orthopedics and sports medicine. It's highlighted here. And then there are 1,000 phone calls where we discuss all of the different aspects that would go into these guidelines. It's a consensus document. And then some volunteers who are either volunteer or are volunteered put pen to paper and write these guidelines. These are 3 to 5 pages long. They are referenced, although the idea is not to produce an academic medicine document, and these are very clinically based. When these are completed, they are affirmed by the full task force, and the names of everyone who participated is on the document. And so if you go to our Department of Health website or the Pennsylvania Opioid Response website, we have all of those guidelines there. Next slide, please. And these have actually all been taken to the state licensing boards. So for instance, they've been taken to the Board of Medicine. We have a separate board of osteopathic medicine. And we have, for instance, the nursing board, and then the dental guidelines to the dental board, the pharmacy guideline to the pharmacy board, and they are all taken there for their consideration and their affirmation and acceptance. So these guidelines produce a voluntary standard of care for opioid prescribing and have been extremely useful. All of these are living documents, and they are all reviewed every 2 to at the most 3 years, and often with some either small revisions or substantial revisions, so that they continue to be updated to follow current medical practice. These guidelines have been referenced by the Department of Human Services, and particularly from Medicaid, in terms of how they do prior authorization for opioids under the Medicaid system. And we actually have had buy-in by the Pennsylvania Insurance Department and commercial insurance companies in terms of prior authorization guidelines for opioids. And so these guidelines have been absolutely critical. Next slide, please. One of the linchpins to our opioid stewardship process has been the Prescription Drug Monitoring Program. That legislation was passed at the end of 2014. It went live in August of 2016. And this has been a critical online tool to support clinicians in identifying patients who are struggling with the disease of addiction and to get them into treatment. Next slide, please. So we have over 90,000 registered users of the PDMP system. We have approximately 1.6 million searches per month. We have an interstate data sharing agreement with 19 states and also DC. And with all of these efforts, but particularly the PDMP, but we have seen approximately a 21% drop in the number of opioid prescriptions that we are seeing. And we consider that very successful, although we have more work to do. Next slide, please. We have worked to integrate the Prescription Drug Monitoring Program into the electronic health record for providers. So that has been very successful, so that it makes it much easier to use the PDMP if it's integrated into electronic medical record of our hospitals and health systems and eventually our physicians' offices. What I've been told by physicians that it has gone from a pain in the neck to an integral part of their medical practice. We also have a program of academic detailing where we have had over 2,300 healthcare professionals complete online education and 1,700 healthcare professionals who have actually completed face-to-face education in terms of prescribing. And so this is called academic detailing to kind of counter the pharmaceutical company detailing, which in many cases contributed to the problem of overprescribing. We also have an integrative data report which looks at controlled substance prescribing and overdose trends at the state and county level as part of this program. Next slide, please. With these efforts, we have virtually eliminated doctor shopping in Pennsylvania. So in terms of the number of patients who go to many prescribers or pharmacies to get controlled substances, it's eliminated. In terms of the patients who go into 5 prescribers or pharmacies, it's virtually eliminated. And so in terms of that aspect, it has been overwhelmingly successful. Next slide, please. As part of the disaster declaration, the PDMP is sharing data with sister agencies, so that includes the Department of Human Services. Our Medicaid office has access to this data. Our Labor and Industry office has access to the data in terms of looking at workers' compensation claims and prescriptions. The Pennsylvania Insurance Department has access, and our Department of State has access. And finally, actually, the Attorney General's office has access. So in addition to being used by physicians to eliminate doctor shopping, it actually is used for the Department of State and the licensing boards and the Attorney General's office to look for pill mills. You know, I think that most physicians who might be over prescribing are doing so because they need education, and there is a program through the Department of State to provide that education. But unfortunately, there are bad apples, and they need to be prosecuted and have their license taken away by the Department of State and prosecuted by the Attorney General's office, and the PDMP is a vital tool for that. Next slide, please. We have a very robust data dashboard. And so if you go to that website, you can see our opioid data dashboard, and it highlights the 3 pillars of our response: prevention, rescue, and treatment. And if you go to the prevention link, you'll see all of these different issues that we've been discussing in terms of the PDMP, in terms of the prescribing guidelines, links to the continuing medical education that's required. We have worked actually with medical schools on student education as well. If you go to the rescue, you will see data about the life-saving medicine naloxone, and you will be able to see numbers about rescues by law enforcement. You'll be able to see rescues by EMS and those numbers, and how to download our standing order prescription so that people can get naloxone by going to any pharmacy based upon my prescription as the state health official. And then also treatment. First, the warm handoff to treatment, and then the expansion of evidence-based medication-assisted treatment in Pennsylvania. Next slide. So, for example, you can see the number of opioid dispensations per year. You can do that at the county level. And you can see that on this an example on this slide in terms of opioid prescriptions per year. And if county officials or medical or hospitals or health systems want to look at that, they can on this website. Next slide, please. So in terms of our opioid command center update, just a couple of examples of things we have done. We actually made neonatal abstinence syndrome reportable, and we have had, unfortunately, well over 2,000 cases reported in a little over a year of NAS. We have a task force to come up with plans of safe care for those babies and their families. We have an excellent Get Help Now hotline. You can see that in over a year we have had over 18,500 calls to our hotline where people can receive information about addiction, the disease of addiction, and receive referrals for treatment. And you can also see that, for instance, EMS has administered over 17,000 doses of naloxone in over a year with rescues. And actually, we are at between 85 and 90% successful in getting patients transferred to the emergency department where we can institute a warm handoff. Next slide, please. So in terms of expanding treatment, the first aspect is this warm handoff, a facilitated referral for treatment. And so we had developed a warm handoff clinical pathway, and that's with the Department of Health, the Department of Drug and Alcohol Programs, and the Pennsylvania College of Emergency Physicians. And this involves actually the hospital calling the county drug and alcohol authority, who will send someone, such as a peer recovery specialist, to the emergency department to try to link them into treatment. That has been very successful, particularly in certain counties. Next slide, please. In 2018, we hosted 6 regional summits throughout the state. You can see an example to the right of some of the things we worked on to identify challenges and develop local work plans to get people into treatment. Actually, starting tomorrow, we are hosting 8 more regional summits a year later to perfect that system and really get to drill down and to get very granular in terms of what exactly are the problems that we have of getting people into treatment. We are actually promoting the protocol of using buprenorphine in the emergency department after the patient is resuscitated, so that they never go through withdrawal, and then making an immediate referral to treatment, such as expansion of outpatient quality evidence-based medication-assisted treatment centers, such as our centers of excellence. We are working to get more and more physicians to get their X waiver for buprenorphine, including as many emergency medicine physicians as possible, so that they can dispense buprenorphine in the emergency department and write, a 2 or 3 day prescription as a bridge to get these people into treatment. And so, I mean, we're being very successful, some counties more than others, and we're going to have these 8 summits. Tomorrow is in Philadelphia, a very challenging place, obviously, to be able to do that. Next slide, please. As part of the warm handoff, actually, we had a declaration of collaboration. You can see my scrawl at the second line, on the second column, the first one. That's Rachel Levine. Doesn't look like it, but that's my signature. To be able to get people into treatment, pretty much 24/7, and to get them into life-saving substance use disorder treatment. Next slide, please. So that's pretty much, I know there'll be time for questions at the end. That is a brief summary of our response. We are very focused on this. It's a priority of Governor Wolf and the administration. It's all hands on deck through our Opioid Command Center. We are looking very closely at our 2018 data. We are seeing a trend downward. It's still preliminary data because we don't have the final data yet in from our coroners. And I believe that we are making progress, but we are absolutely not done, and we're in it for the long haul. So I will pass it back for the webinar, and thank you very much for your attention.
Thank you so much, Dr. Levine. And now we're going to hear from Michael Freeman with the California Department of Healthcare Services. Mr. Freeman's going to share how California convened a cross-sector effective work group to address the opioid crisis and to ensure that their funding is distributed in an efficient and flexible manner. And he's also going to share an update on California's Section 1115 demonstration waiver and discuss how the demonstration has been able to help move partners beyond traditional boundaries. Michael?
Yeah, hi, can you hear me?
Yes, we can.
Okay, great. Well, first of all, I just want to thank NASHP and AASHTO for planning this webinar and for having me on today. And also thank you, Dr. Levine, for sharing the incredible efforts that are moving forward in Pennsylvania. So as you heard, my name is Michael Freeman. I'm from the California Department of Healthcare Services. I'm also the State Opioid Treatment Authority. and the project manager for both of the federal opioid grants that California has received through SAMHSA. So with that, I'm going to share with you some of our cross-agency strategies to preventing and treating substance use disorders. Next slide, please. So I'll start with walking through some of the ways California has worked toward a unified administrative structure over the last several years. So beginning with 2013, the initial step was taken in combining and streamlining functions, which was done by merging the mental health and substance use disorder single state authorities for not just Medicaid, but also SAMHSA and the block grants, as well as the facility licensing health and safety function. Having all of these under one roof was an incredible start to where we are today. In 2014, the California Department of Public Health created the statewide Opioid Safety Work Group, or SOS Work Group, which brings together over 40 state and non-government stakeholder organizations and agencies to improve coordination and expand joint efforts to address opioid misuse, addiction, and overdose deaths. The SOS work group also has 5 supporting task forces that include local and non-government entities as well. Task forces of the work group include communications, integrated healthcare and policy, treatment, maternal and neonatal, and also data. The stakeholders that are included in these work groups are wide-ranging, including our Department of Justice, who oversees our prescription drug monitoring program, our Emergency Medical Services Authority, the Medical, Dental, Pharmacy, and Nursing Boards, our California Society of Addiction Medicine, Drug Enforcement Administration, County Leadership, Public Health Officers Foundations, Department of Education, Health Plans, and many more. So another area of collaboration kicked off in 2015 with our SUD 1115 waiver called the Drug Medi-Cal Organized Delivery System waiver, which received approval from CMS at that time. This waiver includes multiple enhanced services that were not previously in the standard Medicaid program. Some of those services include multiple levels of residential services, not just limited to 16 beds or less, so removing the IMD exclusion barrier. Also, narcotic treatment or opioid treatment program services were enhanced to now include more medications like buprenorphine, disulfiram, and also naloxone. In addition to that, we had case management services, physician consultation services added to a reimbursable service under that 1115 waiver. Currently, we have 40 of the 58 counties in California that plan to participate in the waiver, which will cover 97% of our Medicaid population in California. At this time right now, we have 24 counties that are actually live in this waiver, which is covering about 70% of our Medi-Cal population. So another project that further enhanced our statewide collaboration was the State Targeted Response to the Opioid Crisis and State Opioid Response Federal SAMHSA grants, which began in May 2017. Those grants implemented the California Hub and Spoke system that links opioid treatment programs as hubs to Data 2000 waivered providers, which are acting as our spokes. There's currently 18 hubs and over 215 spokes statewide. Another project that came out of those grants is our tribal MAT project that includes most notably a tribal needs assessment and several other key projects like a tribal project ECHO, MAT champions, tribal opioid coalitions being formed, suicide prevention, and also tele-MAT services. Lastly, I'll mention an area that is kind of the next and upcoming focus for our team, which is in youth services. So next slide, please. So with all of these projects rolling out, each with their own incredibly quick timelines, we utilize a few critical strategies to make those happen that I think can be modeled across the country. So first off, we utilize foundations quite a bit because they are quicker and more nimble than navigating through some of our state requirements. This could be through bridge funding, which was incredibly helpful because foundations could fund projects on a short term very quickly right away before we were able to get contracts executed. Foundations were also able to start pilot programs that we could take and expand on a much larger scale statewide. The foundations are also able to carry the overall message forward for us and generally have missions that align with our state practices. Another area I could not stress the importance of enough is contract exemption authority. Without this, we never would have been successful in these projects, particularly with the opioid grant funding. We have exemptions from competitive bidding, external department contract review, and other processes that can greatly delay implementation and execution of contracts, which ultimately delays execution and implementation of actual projects. This exemption did have to be approved through our legislature. However, they were very much on board because the opioid epidemic has largely been a bipartisan issue, and we didn't really run into any barriers there. We're also lucky to have incredible partners in our public health agency at the California Department of Public Health, and we take every opportunity we have to align and collaborate on our goals and objectives. We've also seen success moving forward several tribal-related projects by gradually building relationships with the tribal community. We found it critical to use culturally specific materials and, most importantly, find someone who is already part of the tribal community to bring messages forward through them. So coming out front with a member of the tribal community and them carrying that message forward instead of coming forward as the state. Lastly, on this slide, I'll mention how the federal opioid funding took us far beyond our usual stakeholder groups. As we know, this epidemic is affecting a wide range of racial, ethnic, and geographic groups, and we want any entity in the state to be able to either treat or effectively refer someone to treatment who walks into their door. And that could be a wide range from hospitals, emergency departments, STD treatment facilities, jails, prisons, primary care providers. So this has really spearheaded our statewide collaboration network, and we're targeting an incredible cross frame of different types of entities throughout the state. So next slide, please. So now we'll move into aligning policies. The 1115 waiver requires all participating providers within each county to adopt at least 2 specific evidence-based practices. Some of these include motivational interviewing, cognitive behavioral therapy, relapse prevention, trauma-informed treatment, and psychoeducation. This creates some alignment and consistency across all counties that are participating. In addition to the evidence-based practices required, all of the opt-in counties are required to utilize the ASAM criteria. This includes an ASAM assessment and then also the availability of various ASAM levels of care across the continuum. So due to this, our department developed a process to actually designate facilities as a certain level of care on a voluntary basis. And then recently, legislation has passed to require all residential treatment providers to be designated by our department with an ASAM level of care. So this is just another example of an eventual statewide alignment on how residential facilities are identified and where they fit into the ASAM continuum. Also through the opioid grants, we've taken the opportunity to work extensively with both county jails and the prison system with our California Department of Corrections and Rehabilitation. So in order to move treatment services forward, particularly for opioid use disorder and to utilize medications for addiction treatment, both systems need to be on board and have availability of services for this to work. As you know, people who are incarcerated are moving between jails and prisons quite regularly, and to not have all FDA-approved medications available in both settings would not allow this project to work. In addition to that, our prison system is in the process of implementing ASAM assessments system-wide, which aims to create an unprecedented level of consistency with community-based SUD treatment systems, particularly in the counties that are participating in the 1115 SUD waiver. Next slide, please. Coordinating data sources, as you all know, is not an easy task. One way we aligned the data was that our evaluator for both the 1115 SUD waiver and our California hub and spoke system were from the same agency, the University of California, Los Angeles. So not only were they familiar with the data sets, they were able to compare across systems and more easily add on additional systems of data once the project kicked off. We're also very excited to be far along on California's first large-scale tribal needs assessment that will be published in the summer and will help guide and target our next steps within the tribal work. In California, we also have an incredible public surveillance data dashboard that is maintained by our sister department, the California Department of Public Health. The data is pulled from various sources, including our prescription drug monitoring program called CURES and the Office of Statewide Health Planning and Development. We have also seen trends related to methamphetamines in California, so that is in the process of being added to our data dashboard as well. This surveillance data can be viewed at a state level and all the way drilled down to zip code specific. It is quite user-friendly and can be toggled to show various views ad hoc. I very much encourage everyone to take a look at the California data dashboard. Another great tool that's part of the dashboard are these two-page printouts of key data by county or at the state level. So when we're running into issues stemming from stigma or county leadership denying that there may be a problem in their area, these handouts have been quite successful in at least starting the conversation as to what's going on in the area. The information altogether in the dashboard has helped guide countless initiatives and policies we have carried forward, including many of the opioid grant-related projects. We're also in the middle of building out a website that includes all of our efforts that aims to show kind of the California model in a sense, so that other states or interested parties can find any and all resources related to the various projects and initiatives we have going on in the state. With over 50 projects just for the response to the opioid epidemic, we're hoping that this will be a fantastic resource once it is completed. Next slide, please. So lastly, I'll move to the upstream prevention. So 2019 looks to be the year focused for us on youth prevention and treatment activities. With various initiatives we are moving forward, it is apparent that more attention can be shown to the youth population. Proposition 64 in California, which legalized marijuana, also set aside sustainable funding for youth prevention and treatment services. We plan to take a lot of what we learned from rolling out the opioid-specific projects and the Drug Medi-Cal Organized Delivery System 1115 waiver and continue those strategies for these youth projects as well. This will again include finding the right partners, including foundations that are interested in youth services, hopefully acquiring contracting exemption authority again, using data available from our data dashboard and other internal systems, and of course, connecting our new projects with existing projects that are in progress. Next slide. So this slide contains some resources for your review, including our website on the opioid grants titled the MAT Expansion Project, also our website on our 1115 Drug Medi-Cal Organized Delivery System waiver, and the surveillance dashboard that I mentioned earlier. So thank you to everyone, and now I'll hand it over to Debbie and Kitty for our open discussion.
Great, thank you so much. And we really encourage folks to join in a conversation with speakers, to ask questions, share resources, and highlight any successful innovative practices in your own states, and feel free to use the chat function if you'd like. To get us started, was wondering, both from Mr. Freeman and from Dr. Levine, from your perspectives, what are some of the hallmarks of an effective cross-agency structure? What has really been instrumental in your states to having an effective structure to get this work done.
This is Rachel, so I'll start. I think one of the hallmarks of our collaboration has been the the marching orders from the governor. I think that the Governor Wolf has expressed that this is an absolute priority for him and for the administration and for our state. And I think that he set the tone in terms of us working together and with such a great collaborative spirit. So I think that that's been very helpful. I think having one person be kind of the incident commander, so to speak, for our command center. So the Department of Health has been lead. Ray Barashansky, one of our deputy secretaries for community preparedness and response, has been our incident commander. And so that has been helpful in terms of the coordination. And I have to say that we're very grateful to the federal government and SAMHSA and the CDC for robust federal funding to support our efforts.
Yeah, and I would echo a lot of those same things. Executive leadership has been key, particularly with our Department of Public Health and then also the Department of Healthcare Services where I am. Our leadership across the legislature. In addition, having this statewide work group, we really work towards aligning goals, taking all input from a variety of stakeholders and really just being inclusive. So allowing people at the table who are really interested in being there. And then of course, the funding has been critical from the CDC and then also from SAMHSA to really, get people to kick off and be a part of these initiatives and want to give input and want to participate.
Great, thank you. Are there other partners in your states that have not yet been engaged that you're thinking would be helpful to start to work with?
So this is Rachel. So the Attorney General's office is a new participant at the command center. And I think that will be very important. For instance, we have worked out a relationship that if they are going to arrest a clinic or shut down a clinic or arrest a doctor who might be a bad apple, as we've said, right after that occurs, they're going to let us know. Because that's a very dangerous time. If you have a physician or a clinic that's closed down, you might have 1,000 or more patients who are now cut off from their opioid pain medications. And if some arrangements aren't made to address those patients' needs and intervene with some type of referrals, then those patients are at risk of going to the black market and then getting heroin or even fentanyl compounds. So they will work with us so that we can intervene. And we have had some discussions with the CDC about their rapid action task force that might actually help us with that. So the AG's office is a recent addition.
And this is Michael from California. I feel like we have done an incredible job really trying to target all of the areas that should be at the table. I think it's just important to stress that populations that are more adversely affected by the opioid epidemic and substance use disorders should be a focus of being included at the table, particularly the tribal community. And then also in California, we have some rural counties and rural areas that are disproportionately affected and need to be included from the beginning, which I feel like we've really done a great job in getting everyone to the table.
Great, thank you both very much. Any other questions before I turn it back over to Deb?
Well, this is Rachel. I want to make another comment about collaboration. So we are also collaborating with the city of Philadelphia. And the commissioner of the Health Department of Philadelphia is separate from our department. And so they don't report to us, but we collaborate. You know, Philadelphia, the opioid crisis is throughout Pennsylvania, so including urban areas, suburban areas, and rural areas. And Pittsburgh has had its share too. But Philadelphia and the Kensington area is really the hot zone for this and requires its own tailored responses. And Commissioner Farley has been working very hard on that, but we're very pleased to collaborate and try to help with that. That's extremely challenging special circumstance.
Great, thank you. And thank you again. It's been really helpful to have for NASHP and for ASTO in these conversations to have the perspectives of Pennsylvania and California at the table. So really appreciate your thoughtful participation. And I will turn it back over to Deb.
Great. Well, I want to thank everybody. Our contact information was at the previous slide. There it is. You can find any and all of us through these email addresses. And please do reach out. And on the next slide, you will see our evaluation link. Please take a minute and visit it and let us know your response. We can't do our jobs better if we don't know more about what your experience is on the other side. The report is available about the Cross-Agency Leaders Roundtable at this link. And I just really invite you to connect with us if you have any additional questions or comments. I thank you all for joining us, and I just want to thank our partners again at NASHP and our presenters, Dr. Levine and Michael from California, for the excellent work and information that you shared with us today. So thank you.